So MET strategies for lung cancer have been explored for a long time now, and many early studies were negative, in part due to patient selection, and I think lack of full understanding of the complexity of the MET signaling pathway. So now we know that the MET pathway is important in direct signaling through multiple other signaling pathways, and can also connect with other tyrosine kinase pathways and result in resistant mechanisms and activation of other pathways. And so in this complex signaling, direct inhibition of MET may not work for all patients equally well. And so based on that, there have been identification of mutations, amplification. The MET XN14 mutation has probably the best data thus far, and crizotinib leads to about a 40% response rate, and based on that is going for accelerated FDA approval. So we're moving to an area where we know that MET inhibition can affect at least certain populations. And again, most specifically, MET exon 14 alterations and MET amplification. Beyond that, I think we're looking at how to target more people with MET, and there have been some combination therapies or multi-targeted therapies that have shown in part that MET can be beneficial even in wild-type patients. And there are some new drugs that are bispecific antibodies to MET or MET and EGFR, trying to overcome resistance, and importantly, resistance to osimertinib, the third generation EGFR TKI. We know that a large proportion develop MET amplification, and there are studies ongoing looking at combinations, looking at MET inhibition and EGFR inhibition that may overcome resistance for these patients and again help them live longer and better.